Good morning and welcome everyone to our roundtable today on First Do No Harm. We're very excited to have Helen Graham present, and Helen is in the College of Nursing. And at this point, I really would like us just to start having Helen introduce herself and start the program.
All right. Thank you, Tracy, for the introduction. And I just want to thank everyone for joining today. I know this is a busy time of the semester. I guess I'm always busy, actually. And for taking time to join this, my presentation on First Do No Harm. So what I'd like to do is for this presentation, talk briefly about my clinical background, which leads into the project that I did for the Daniels Fund Ethics Initiative. Then we're going to do a quick review of those principles, of the Daniels principles and the assignments that were created, as well as a quick definition defining cardiac rehabilitation, which is going to be part of that assignment. And then I'll take a look at the future for the Daniels Fund at the Johnson Bethel College of Nursing. So if you'll take a second to just read that little Henry Fielding quote that I have up there, basically says how I feel about my career in nursing as a clinician as well as in academia, and for the privilege of being able to be a Daniels Fellow this year. So I start out with the next slide here on my clinical background. Shortly after I finished nursing, undergraduate nursing program, I went to work in the emergency room in upstate New York. And I, like every other emergency room nurse, saw surgical, medical trauma, and I gravitated towards the cardiac cases. That was where my real interest lay. So upon getting married and moving to Washington, D.C., I got a job at Georgetown University Hospital in the surgical cardiovascular intensive care unit. I continued to study and learn about cardiac nursing, and we got transferred eventually to Colorado Springs, where I got a position at Penrose St. Francis, fortunately in the cardiology department, and eventually became the manager of the cardiodiagnostics in the cardiac quality improvement department and cardiac rehabilitation program. Cardiac rehab was my real love, and you'll see that as throughout the presentation as I talk more about that. After 25 years at the hospital, I transitioned into academia and came here to UCCS. While at the hospital, with their support, I was able to complete my graduate studies at the University of Colorado, a health science center up in Denver. While there at the university, I took a course on nursing ethics. This was a while ago. And that course was with Dr. Sally Ghetto, who some of the nurses on the call may be familiar with. Dr. Ghetto is a nurse philosopher, and she taught in the School of Medicine up there in Denver. She taught ethics course, and as well as then eventually moved over into also teaching nursing ethics. And this was kind of like the early day of teaching ethics in nursing, where you had real course for it. Anyhow, while in her course, a classmate of mine, Robin Lindsay, and I, we wrote a paper. And then the paper is relational narratives, solving an ethical dilemma concerning an individual's insurance policy. And this had to do with a patient coming into cardiac rehabilitation. The patient was a young 28-year-old young gentleman, junior executive, recently married, and very athletic, a cyclist. And he was actually a cancer patient, not a cardiac patient. That's where the note of interest is. This individual, his prognosis was not real favorable. And the cancer, the way I came in was the cancer was wrapped around his aorta, unfortunately. He had a sarcoma and involved the heart. So he was obviously down in the dumps and wanted to exercise. And we wanted this individual to be able to have a life after he got out of the hospital. And we wanted to help him. So our cardiac rehab department, we got together and we looked at how we could possibly get this individual cardiac rehabilitation benefit. And so what we did is did this study. Well, I want to say this study tells what we did to help this patient. Between numerous phone calls with the insurance representatives, we not only got this individual 2 or 3 visits, but we actually got him full benefits of 36 visits for over a 3-month period. And this particular patient did very well in the program, and he had 5 more years of good quality life. So when I saw the opportunity to begin again to participate in ethics, the Daniels Fund Ethics Initiative last year, I quickly jumped at the chance so that I could immerse myself again with students in ethics. Code of ethics let's go to code of ethics. There's a number of code of ethics in healthcare, as you're probably aware of. You know, the American Medical Association, the American Nurses Association has code of ethics. And this is all good because when students, brand new students, particularly in the undergraduate program, come in and are about to start their first day on clinic, I mean, one of their first concerns is they don't want to hurt or harm their patient. So students are taught do no harm. And I want to ask this group is, where do you think the do no harm comes from, the saying do no harm? So raise your hand if you think it comes from the World of Medical Association International Code of Medical Ethics. Now, or does it come from the Hippocratic Oath? So raise your hand if you think it comes from the Hippocratic Oath. Does anybody know how to, let's see, where I don't have an icon for raising my hand. Tracy, I don't know if you can see that or not. No, well, moving right along. I'm not sure if anybody raised their hand, but first do no harm comes from the Hippocratic Oath. This oath reads, I will prescribe regimens for the good of my patients according to my ability and my judgment, and I never do any harm. So the AMA, as I mentioned, the American Medical Association has their own code of ethics. There is controversy with some about whether or not we really need to have an American Nurses Association code of ethics. And I strongly believe that we do, because we face different circumstances than physicians and other practitioners. So we see patients on a daily basis. And again, as I said, those dilemmas come up that are different perhaps than what the physicians face. So I think this is really good to have. And then last there, you see I have the institutional review boards, and you know that they have also as well 3 principles that align very closely with what we see in the code of ethics for the other 2 associations. When we think of do no harm, there's acts of commission and acts of omission. Commission is doing something wrong, and that would be like perhaps amputating the wrong extremity, giving an overdose of medication or the wrong medication, or perhaps doing surgery on the wrong patient. Omission is the failure to do something right. Yes, a failure to do something right is an act of omission. All ethically issues involving in these type of acts. So I think when people hear do no harm, at least on my side, in the medical area, the nursing area, we think of catastrophic situations. However, most situations are not going to be catastrophic. And what I'm going to talk to you today about is not a catastrophic situation. The case study that I put together for one of my courses, which I will tell you about shortly here. The next slide. As I mentioned, nurses from day one are wanting to make sure that they don't hurt or harm their patient, and they protect their patient's rights. They have ethical obligations to their patient. I want to show you, and I hope this clip works. This clip that you're about to see shows you the extent a nurse will go to protect her patients. The following is a real life situation that occurred several years ago involving a nurse named Alex Woobles. Her case gained national attention, and she was unlawfully arrested while she was on duty at the University of Utah Hospital. She was arrested for obstructing justice while following her hospital policy. The hospital policy was not to allow blood draws to be drawn, particularly by like a police officer, without a warrant or without the patient's consent, unless the patient was under arrest. And in this particular situation, the patient, you will see, was not under arrest. So this is a 2-minute clip, and let's see if it works.
4 days after the release of that video of Nurse Alex Robles being manhandled and handcuffed by Detective Jeff Payne, the hospital today said it will no longer allow police to interact directly with medical staff involved in patient care. We're done. You're under arrest. Detective Payne became angry after Nurse Robles said it was illegal for her to draw blood from a truck driver involved in this crash involving a car being chased by police.
There's absolutely no tolerance for that kind of behavior in our hospital.
Indeed, the Supreme Court ruled last year police must have a warrant or consent to take blood. Today, Nurse Wobbles, a former Olympic athlete, said Salt Lake police were slow to take action. Only after the video shot in July was released were Detective Payne and another officer placed on paid leave pending a criminal investigation.
I'm not here to police the police. The police need to do that if they're going to regain any kind of trust by me or, I think, the public.
Outraged citizens have protested, jammed 911 lines, and posted thousands of Facebook comments for Payne to face criminal charges.
If they are not held accountable, that will further erode the public's trust in police officers generally and in this police department in particular.
The mayor and police chief have both apologized. Detective Payne isn't commenting. And it turns out the patient who Nurse Wobbles was protecting is William Gray, himself a reserve police officer from Idaho who was never accused of any wrongdoing. He and his department have thanked Wobbles for standing up for him. Hey, NBC News fans, thanks for checking.
Okay. There we go. So yeah, so that is a nurse who really went to all extremes to protect her patients' rights and ethically did the right thing. So now let's move on to what I did as part is, you know, those that have been a fellow before, part of being a fellow is being able to share your assignments or class experiences with in a presentation. So I did that. And first, what I did when I became a fellow last August was I wanted to see what was already being done in the School of Nursing here at Johnson Bethel. And so I queried a few of the faculty members back in September to find out. And what I found was similar to what Dr. Deborah Kinney found when she was a fellow, I believe it was last year, in her report, was that ethics is pretty well integrated in the graduate nursing programs and the undergraduate nursing program. Now, ethics in our nursing program can range from anything to a page or two in a textbook to a chapter. And then we have senior instructor Sue Davis here at the School of Nursing, also a former fellow, who created an elective course called Nursing Ethics, and it's great. However, not all nursing students take this course, which hopefully a good number do, though. And then I feel confident that ethics is well integrated into our program and into nursing programs. First of all, nurses, upon graduation, nursing students have to take an NCLEX exam, and they have to pass that, and they have to be prepared because there are a lot of questions, and including ethical questions and legal questions on that examination. It's difficult to objectively measure the amount of content of ethics that nurses have in their undergraduate program. We can also pretty much assume that ethics is well integrated based on the fact that for 20 consecutive years, nursing has been rated by the Gallup poll as the most honest and ethic of professions. And 85% of the public that vote have rated nursing up there for honesty and ethics. And the next profession under that would be your engineering and your physicians and pharmacists, who rate at 66%. So it's looking good. So where does Daniels fall in with all this, the Daniels Fellows Principles? Well, some of you are, and probably most of you might be familiar with those principles, which you see to the left of the screen there. I'm not going to read them, but if you'll just take a second to look at what the principles are, and looking to the right, you will see the biomedical principles as well too, ethics principles. There's a lot of overlap between where the principles come from, as I say, AMA, and the Daniels. The Daniels principles, I believe, were built based off of a business acumen or business model. Whereas obviously the nurses and the medical were a business medical model. So here at the school, I teach 2 undergraduate nursing courses, several sections of nursing professional practice, and I also teach nursing research. So what I did was, for the professional practice, I wrote a case study. Created 1 new case study, and then for the research class, I added 3 ethical related discussion questions. And first, what we're going to do is talk about is the case study. This is long and you don't have to read it, but this is based off a actual situation. I've changed a lot. It was not even a female patient, but an individual who had a heart attack. In this particular case scenario, however, Mrs. K, I just want to tell you briefly, she's a 68-year-old Hispanic woman who has had her 2nd heart attack. She's now recovering in the unit after having coronary bypass surgery. After her first heart attack, she did not participate in the outpatient cardiac rehab that her cardiologist had advised her to participate in. She felt that she was more needed at home by her grandkids and particularly by her husband. She needed to be at home and not at the cardiac rehab program. Since her first heart attack, her husband's passed away now, and she's a widow, obviously. And as I said, this is her 2nd heart attack. And she is once again a candidate for the outpatient cardiac rehab program. And this time she is interested in attending. She has a new cardiologist, or other cardiologist has left town, and Mrs. K, the patient, her nurse comes in to talk to her about her discharge planning, and her nurse, while talking to her, tells her more about the cardiac rehab program, and she tells her the benefits of attending, and she explains that it's an intervention that she should participate in within 2 weeks of being discharged from the hospital, because the results are even better if you get into the program earlier. Now she's really convinced that I'm going to do it. This is what I want to do. There is one problem, however. Mrs. K has a new cardiologist. And prior to Mrs. K's discharge from the hospital, the cardiologist does not want her to participate in the cardiac rehab program. Unfortunately, this cardiologist arbitrarily refuses to send his patients to outpatient cardiac rehab, believing he's better to educate his patients and follow up with them in 6 to 8 weeks after they're discharged from the hospital. Now, a few things to know about cardiac rehab is that cardiac rehabilitation program is an outpatient program reimbursed by Medicare and most insurances to attend for 3 months, 3 times a week. The program supervised by a physician, staffed with registered nurses, exercise physiologists, dietitians, in some cases counselors, to provide exercise for individuals who've had open heart surgery, a stent placement, or a heart attack. And to use education like tobacco cessation and exercise, as I mentioned, medications, stress management, etc. Now, there are a number of ethical issues that have come to light in the past, I'd say 5 to 10 years, about referrals to cardiac rehabilitation. Unfortunately, referrals for outpatient cardiac rehab, although it is a covered benefit, 40 40% of patients. The numbers vary from 30 to 50% of patients that are eligible for the program are not referred by their physicians to attend. Disparities exist. But 36% fewer referrals for Hispanic individuals and other ethnic races as well too, compared to whites, and 12% fewer referrals for females compared to males. And as you would have guessed, middle-aged adults more often referred to outpatient cardiac rehab than older adults. It's important, before I go to the next slide, to keep in mind that referral is, as I said, needed. You have to have a physician order to participate. Looking at this is out of the Canadian Journal of Cardiology, this little slide that you see here. I want you to pay attention, please, to the left of the slide where you see the blue bars, and that is referrals into cardiac rehab. 40% it's averaging around there over the trend. And then an intervention called automatic referral into cardiac rehab programs was implemented. And you can see the blue bars to the right. The automatic referral went into the medical record of the patient prior to discharge, and you can see a large increase there of referrals into cardiac rehab, which we actually did those automatic referrals at Penrose St. Francis probably about 15 years ago, but it's not required. It's not required that you have automatic referral, but we do see great increase in participation. So the students had this case study, nursing students, and they were asked 2 questions. They were asked which of the Daniels principles, which they had handouts that had talked about these principles and what they meant, et cetera. And they were to identify which of the principles were ignored in Mrs. K's case. And they took a look at that, and I have a survey, and I'm going to give this a try, and I hope I don't lose it, everybody, but see if the survey will come up. If you will just click 3, and given what I've told you about Mrs. K, who's not being referred to the cardiac rehab program, who'd like to come in, and I did not touch on the benefit of participating in outpatient cardiac rehab, is that there is a 20 to 25% reduction in mortality for individuals who do participate, so fewer deaths, as well as a significant reduction in second heart attacks and readmissions. So that is the benefit of coming into cardiac rehab. It is also a class 1 recommendation by the American College of Cardiology. And what does that mean? It means that there's strong scientific evidence that supports participation in cardiac rehab as having positive outcomes, as I said, fewer deaths, et cetera. So given that scenario of the patient in the hospital, the nurse talking to the patient, the physician being in the position he has, which of these principles jumps out at you? So let's see if this survey comes up. Can you see the survey? Let's look at what the students felt, what response I saw from students. So we see that most students replied to the integrity piece, that the integrity jumped out at them. And then you see that with trust and respect and fairness and accountability, all about the same as far as ethical concerns that they had, and fewer for viability and rule of law. Now, those of you that are familiar in nursing with those 2 principles, they are a little bit more difficult to apply. They're more on a business side. The viability having to do with long-term value for stakeholders, et cetera. On to the right, there is what comments students made, which was that doctors, as far as integrity, they need to be more open with their patients and include their patients in decision-making. Transparency, physicians not being open with patients when not letting her know about the covered benefits that she's eligible for was not ethical. Patients put a lot of trust in their physician, and they really expect no withholding of information, particularly patients in rural parts of a state, older patients, particularly older patients. They really have that trust, and so would not suspect that they were not being told about benefits that they're eligible for. In fairness, this woman obviously is not receiving fair treatment. A patient in a bed next to her, who is her age, may be going to cardiac rehab and receiving that benefit in this situation, the case. And respect, not respecting the patient's rights and accountability. Physician has to be accountable to that oath, that Hippocratic oath, do no harm. Though this is not really doing harm to the patient at the moment, if we remember the act of omission and not doing something that we're supposed to be doing for this particular patient, not being prescribed the cardiac rehab program, you already heard that as far as mortality and a repeat event, that's percentage of that happening is more likely. Viability, long-term prognosis for this patient in jeopardy. Could she have a third heart attack down the road? You know, that this could be a contributing factor among other things. And so the other is that it is a strong recommendation among the American College of Cardiology and the American Heart Association, and that's being disregarded in this case. Okay, Tracy, I'm ready for the next slide. Let's see time-wise where we're at. So the nurse wants to advocate for this patient. What would the nurse do in this situation? And I asked the nursing students, what would you do in this, if this were you? I asked this question, as I said, there was a situation that I encountered that was really similar when I was involved in cardiac rehabilitation. And basically when questioning the doctor had the asking about the case and situation, basically had the door slammed on my face. I hope we won't go into that now, but creates an uncomfortable situation for those around, as well as the practitioner and patient. It could create a very uncomfortable situation. The doctor, I believe, can be acting in a way that thinks that he can best manage this, and maybe perhaps could, but it's a very authoritative and perhaps paternalistic approach in this particular case. What did the students say? Well, most students, as you probably would guess, they would try to discuss directly with the cardiologist. They would start there. And if that was not effective, the nurse would then discuss it with their manager, and some felt that they would like to take a team approach to managing this. Some pointed out that they were very aware of the tensions that could arise, and in this situation, how very important indeed to involve leadership. So the takeaway is respecting the rights of the patient and the members of the team when we see differences of opinion exist, which indeed that will happen. Okay, next slide. For the nursing research course that I teach, I created 3 discussion questions. And the first discussion question had to do with publishing unethical research. And the question for that was, do you think findings from unethical studies like the Nazi study should be published, and why or why not? For those unfamiliar with the Nazi study, the Nazi physicians background in World War II, they had conducted experiments in some situations. They tortured patients with extreme cold and high altitude, which in some cases led to death, disfigurement, and disability. Following those experiments, the German Medical Society published in their journals and in court documents the findings from those studies. The data, while helpful, was was an unethical study. And so students were asked to respond to that question. And I want to go, Tracy, I think it's going to be, you're going to move forward to, there's the questions, that's discussion 1. And let's go to the next slide. Okay, actually go back one if you don't mind, please. The majority of students in this particular research class believe that the data from the Nazi studies should not be published based on the unethical means in which they obtained the data. If the results from the data are collected and were published, this would encourage other unethical studies in the future, meaning if they were to take data from that Nazi study and do a secondary analysis, does this encourage other researchers to do unethical research? Very few thought it was okay to publish based on the fact that it is good data from the study, and which cannot be debated that it is good data as far as that goes, but it's totally unethical. One student asked in the discussion question, what if in another study that was found a cure for cancer, but the ethical issue like improperly handling the data or collecting the data were to occur during that study, should those findings be published, particularly if the data and the findings could save lives? Why do unethical studies get published was one student's question. The majority of the class found very value in talking about unethical studies. Students were very invested in this question. They took initiative to add links to other unethical studies for the class students in the class to benefit from. So that turned out to be a good discussion question. The second discussion question there is COVID testing. And at the time when that question was written, the testing on children was still underway. It had not been approved yet to give to children under 12. So it was a good, timely question. Parental consent is needed, and did the students have any ethical concerns about this? And again, a real life situation. I included this question because I had actually encountered a situation after my my son was born. And in talking to the doctor asked for me to sign my son up for a study. They were doing blood studies, and I was to bring my infant in every day for the next 10 days to the hospital to have blood draws. Well, I turned it down participating in that study based on the fact that I would have to travel over a half hour to get to the hospital. That's just getting there, not coming home. So time-wise, it was not going to work. The doctor became irritated actually and told me that that I had an obligation to participate in the study because we didn't have enough people from the other side of town involved in the study. So I understand where he was coming from, and I know he meant well, but I felt like I was being pressured and uncomfortable and not being heard. And so whenever we involve children in testing, we have to be concerned about coercion in that situation because it can occur. And one of the students, when she answered this question or talked in the discussion room about it, she herself had been, her mother had put her into a study several years ago. She was, much younger. And she said that she did not like being in the study. She was uncomfortable with being in the study. And that was an interesting comment. Whereas I'm sure that's not the situation in many studies. And the students all recognize that we need to have children under 12 in studies when we're testing and doing trials. However, the majority of the students said that they would not enter their child into a study. So interesting. Anything else that they had? They just said that it would have, the informed consent would have to be closely supervised. Really, the physician should be the one explaining the informed consent for the child, parent to give consent for the child to be in the study. However, as we know today that offices are very, very busy, and sometimes that informed consent may be quickly put in front of a parent, and questions need to be answered, and they need to allot for time to have those questions answered to be respectful. And they have to respect the right that the parent, as I said, and the child can say no as well too. So the last question that we had is a nursing student tells his instructor about a great survey he's done, and he wants to do this research project next semester. Now, the following months or months later, he sees in the College Communique newsletter that this instructor went ahead and did a survey, just exactly like the survey he had discussed with his instructor, and asked the students what they thought ethically about that. So the students felt that it was morally wrong, and that it was a form, obviously, they said, of plagiarism for stealing another's idea. They're about 60-40 split on this. They're about 40% of the class felt that it was okay. I'm not sure that they really understood a whole lot about research yet at the point of when this question was asked. There was one comment, there was a relationship built between this instructor and student. Obviously, did this instructor take this as a position of power that that particular instructor could go ahead and do the survey? one student said, "You snooze, you lose." I was kind of taken back with that, meaning that, the student should have done it first, which again, I think it's lack of understanding. Students can quickly put together a research study or survey of that nature. Other students wanted more information, like tell me more about this conversation between student and instructor. They had some good questions, and I think that's justifiable. So that question will have to be tweaked for next year. At the end, we all know what FCQs are and the student satisfaction for the course and in the instructor. And one of the comments I had was that a student wrote, these ethical discussions brought interest to the ethical portions of nursing research, which is so much needed, and appreciated having those ethical discussion questions. Asking this group, looking at the perspective of the students on the ethical issues involved in these 3 discussion questions, and does anybody see any perspectives that were perhaps not addressed, or issues that were not addressed, or students had not pointed out? If you do, please just jump right in. Okay. Tracy, if you could advance to the next slide, thank you, please. The fellows, Daniel's Fellow Ethics Initiative future goals for me and for other fellows here from the School of Nursing. As I mentioned early in the presentation, when I started the semester, I found and talked to several. We have, I believe it is 3. Yes, 3. There's 4 of us now, former fellows of Daniel's. And I started talking with Dr. Mary Claire Wall and asking her, I said, is there something we can do, like an alumni group, or work with us get together, to be able to keep the wheel in motion for ethics in the program? As I said, it looks like it's well integrated, but I think being a fellow, as Tracy says, being a fellow, once a fellow, always a fellow. And I didn't want to see at the end of this year come to an end and just be done with ethics. I wanted to, as I said, look at options and actions and stuff that we could take in the future. So Mary Claire and I had really good discussion about the potential of bringing students in. And with that, I spoke and also brought in senior instructor Susan Davis and Dr. Deb Kinney as well too. And at one time or another, the 4 of us have been able to talk a couple of times about ideas moving forward. And we really want to, I don't believe we've had any ambassadors, nursing student ambassadors, and what really wanted to work on doing that in the future. And we're going to address it come next semester, fall semester as well. In between, we hope we get somebody nursing faculty in on this call that will be applying to become a fellow in the coming year. It's a great privilege, and it's a real honor, and it really, it assures that we're going to keep that ethics going in our courses so that we can continue to be, produce nurses, and the Gallup poll ratings still continue to be high by integrating ethics in our courses. So we're going to do that. And speaking of integrating ethics in courses, I'm putting together this summer a nursing informatics course for the first time. We much need that. And I see so much opportunity for being able to put nursing ethics, integrating that into that course. I'm very excited for doing that. We hope to, the alumni group, as I call it here at the school, talked about, and I believe Susan Davis had this idea of getting together with the ethics committees at Penrose St. Francis and UC Health, and doing some type of presentation for students as well as faculty. And that's on our dream list for next year. So we're hoping to do that. And the next slide, Tracy, please. Thank you. There you have the references that in its back one slide. And in that is the article that I wrote with Lindsay on relational narratives. And that's using an ethical framework of feminist theorist. So that was kind of a fun paper to write. Any questions? And that wraps that presentation up. And does anybody have any questions? And before you have questions, I just so apologize for losing control of my Zoom today. So anyhow, but if you have questions, just jump right in.
Helen, this is Mary Claire. I'm sorry, I have to go on to another meeting in a few minutes, but I wanted to just say it was an excellent presentation, got me thinking about a lot of things. And one thing I think we are at a really good time to really enhance ethics in nursing, because with the pandemic, it has brought up so many different ethical issues. And I was thinking about that when you were talking about your first case with the doctor that wouldn't refer his patients to an evidence-based program. To me, that's malpractice, and it's the same thing, no different than holding healthcare providers accountable to the evidence behind vaccinations and giving their patients false opinions and whatever about the vaccine's effectiveness. So anyway, I think it's just stirred up a lot of thoughts for me, and I enjoyed all of your examples.
Thank you, Mary Claire. And I think that's an excellent comparison and so important as far as the vaccines and as well go too. So great comparison. Thank you. Thank you for joining. And I look forward to working with Mary Claire next year on ethics within the School of Nursing. So yeah, glad to have her here.
So I think I'm the only one. So I'm one of the things that we are working on that nursing educators might be interested in is the ANA has a advisory group called the Ethics Advisory Board. And there's a subcommittee to that group, which is the ethics education. Excuse me, a little tickle. Ethics Education Subcommittee.
It's very dry. It's so drought. Take your time, Deb. If you need some water. It is allergy time.
Oh yeah. Anyways, this subcommittee is working on a and it's got a whole bunch of people who are really heavy into ethics across the United States in nursing. And we are putting a toolkit together for educators based on the REST model, which was a model by some guy named Rest. And it begins with moral awareness, then moral judgment, moral intention, and moral action. And so that toolkit should probably be coming out because we just contracted with the NLN to make 3 2-hour modules, CNE modules for ethics education for educators. So I just thought you might be interested in that.
Very much so. And really glad to hear that. And as you say, if we can participate in any way, perhaps when that toolkit comes out, Deb, if you can, share with us or send us a link so that maybe perhaps some of us could also be on that subcommittee or think about joining a subcommittee to know more, or even just to know more about this subcommittee. I would be interested, and I bet some of the other people on this call would be interested too.
Okay.
So, yeah, it's exciting.
Yeah. So yeah, I mean, like I said, it's going to be coming out with these modules, and as soon as we get the modules done, we'll let you all know.
Perfect. Thanks, Deb. Yes, and thank you, and thanks for the opportunity to be a fellow. And I just can't thank everybody enough that's on the call, that joined in this call today. So thank you so much, and you all have a wonderful rest of the semester. Bye-bye.
Bye.